We move on to the same question regarding diffuse large B-cell lymphoma, and Kieron Dunleavy will go into the topic. Welcome.
Yeah, thanks for the introduction, and thanks to the Lymphoma and Multiple Myeloma Hub for the invitation to participate in this symposium. These are my declarations. So in contrast to multiple myeloma, aggressive B-cell lymphoma is highly curable. About 70% of patients are cured with standard immunochemotherapy, but still 30% of people are not cured with standard therapy, so there is a need for other treatments and treatments in the relapse setting that work very well. And CAR T cells work very well in patients with relapsed diffuse large B-cell lymphoma. The FDA and the EMA have approved all of these three products. They all target CD19. They all have different co-stimulatory domains, and the pivotal trials that were done were ZUMA-1, Juliet, and Transcend. In terms of the approved products, the trials that led to their approval were all a little bit different. As you can see here, the conditioning chemo was different, dose level of the CAR T cells was different, but for the most part, they included patients with diffuse large B-cell lymphoma, some with other types of aggressive lymphoma as well. And as you can see at the bottom, the response rates were excellent in these studies, and this led to the EMA and the FDA approving these products for patients with relapsed diffuse large B-cell lymphoma. These curves are very important. I think these are the overall survival curves and progression-free survival curves from these three pivotal studies. And as you can see, with pretty long follow-up, close to 50% of patients are still alive having had these products, and the progression-free survival is somewhere around 40% in these three studies. So one big question at the moment is, will CAR T-cell therapy replace auto-transplant in the second-line setting? So for patients with diffuse large B-cell lymphoma who relapse, we have traditionally highly considered auto-transplant as the next line of treatment. So because of the effectiveness of these agents in third line and fourth line and beyond patients, 3 studies were done looking at this particular question. So in these 3 studies, ZUMA-7, Belinda, and TRANSFORM, patients had to have a diagnosis of high-risk large B-cell lymphoma, and either they had to have relapsed within a year of finishing treatment or be refractory to frontline treatment. And essentially, in all 3 studies, they either received CAR T cells or they received salvage therapy followed by autologous transplant. Two of these studies were positive. The ZUMA-7 study and the TRANSFORM study were positive. So they showed that CAR T cells compared to auto-transplant was advantageous in terms of the primary endpoint, which is event-free survival. In the ZUMA-7 study, the event-free survival was 8.3 months versus 2 months for those who got the CAR products compared to auto-transplant, and in the TRANSFORM study it was 10 months versus 2.3 months. And I should say as well, this is very topical at the moment. A paper just came out last week looking at long-term overall survival in the ZUMA-7 study, and there was a significant advantage with very long follow-up, and that was published in the New England Journal of Medicine last week. So what matters in CAR T-cell response in aggressive B-cell lymphoma? A lot of different factors, obviously. First of all, clinical characteristics, and we've already been talking a little bit about this. There's no doubt that patients with higher tumor bulk, higher LDH, have a worse outcome. The more lines of treatment you've had, the worse the outcome is. And IPI characteristics have been looked at as well in all of these various studies. What about tumor biological characteristics? In lymphoma, these are really important. And we still really haven't got to the bottom of this in terms of differential activity of CAR T cells among different subtypes of aggressive B-cell lymphoma. I'll talk a little bit about some of the studies that have shown an advantage in the ABC subtype. And I'll talk a little bit about high-grade B-cell lymphoma as well, because I think some of the results that we've seen with CAR T-cell studies are very interesting. Of course, the tumor microenvironment is really important. We don't understand it very well in terms of the effectiveness of CAR T cells, but there are studies and hypotheses that there may be some tumor microenvironment factors which may make CAR T cells work better or less. And we're also doing a lot of studies looking at interval response assessment, both with PET imaging and MRD dynamics. And a study just came out from Stanford actually looking at MRD in the context of CAR T and showing that can predict outcome in certain patients. So the molecular biology of diffuse large B-cell lymphoma is pretty complicated, as shown in this slide. About 20 years ago, gene expression profiling divided most cases into the ABC or the GCB subtype. 20 years later, there are now several genetic subtypes, and these have certain hallmark genetic features, and these subtypes are associated with the presence of certain mutations. It's interesting, these studies shown here are small, but they're are differential outcomes following R-CHOP with some of these different genetic subtypes, and that really sets the stage for candidate drug targeting in the future. And if we think of aggressive B-cell lymphomas, they really lie on a spectrum of diseases with diffuse large B-cell lymphoma, NOS, on one end, and Burkitt lymphoma on the other end, and high-grade B-cell lymphoma is here. Now, in the last WHO classification, most high-grade B-cell lymphomas had a MYC BCL2 and or BCL6 translocation, and then a minority of them were called high-grade B-cell lymphoma NOS. In the current WHO classification, they've removed the BCL6 cases from high-grade B-cell lymphomas, so this group now just have MYC and BCL2. And to confuse matters a little bit, the international consensus classification is another classification system that has recently come out. And in that classification system, they have included high-grade B-cell lymphoma cases with MYC and BCL6 as a separate category. So if we look at the ZUMA-7 study, what is the impact of biomarkers on outcome? And shown here are a number of different clinical and tumor biological markers. It's interesting that older people particularly did better if you look at hazard ratios. And also, if you look at diffuse large B-cell lymphoma, the activated B-cell cases did particularly well. Also, high-grade B-cell lymphoma cases with MYC and BCL2 and or BCL6 had a particularly good outcome. This is a study that looked at tumor burden. So it showed that low versus high, the metabolic tumor volume was associated with an improved outcome in terms of PFS and OS in patients who were treated with axi-cell. What about the impact of these biomarkers in the TRANSFORM study and the Belinda study? The Belinda study was a negative study. I'm not going to talk about that, but in the TRANSFORM study, the impact of all of these biomarkers was quite similar to the ZUMA-7 study. One of the differences was that older people didn't do quite as well, and also this preferential activity in the ABC subtype wasn't seen in the TRANSFORM study. So what about CAR T-cell therapy in high-grade B-cell lymphoma? So we now have a number of CAR T-cell studies that have included a proportion of cases with high-grade B-cell lymphoma. And it's really interesting because the response rate for this particular subset of aggressive B-cell lymphoma is very high in these various studies. And in real-world data as well, this has also been shown where patients with high-grade B-cell lymphoma have done particularly well with CAR T-cells. It's really not clear why this is. Are there certain biological features of high-grade B-cell lymphoma that are different to diffuse large B-cell lymphoma that give these cases an advantage when they get anti-CD19 CAR T-cells? There have been a lot of different proposals in terms of potential hypotheses, signaling through PD-1 and LAG3, high-grade B-cell lymphoma has a different tumor microenvironment, and this also may help activity of CAR T cells. And also, we talked a little bit about interferon gamma, and this is reduced in high-grade B-cell lymphoma, which may, again, be advantageous in respect to outcome with CAR T cells. So to conclude, some of the key questions in aggressive B-cell lymphoma are which patients should get CAR T-cell therapy in first relapse? Which are the most important biomarkers? Obviously, all of them are important, but how can we use these biomarkers to select therapy for patients, or to, as we enter into other treatments like the bispecific antibodies, which are now being approved in the third-line setting, should we be selecting some patients for CAR T and some patients for the bispecific? So these are really interesting, important questions for the future. It's not clear that CAR T cells are better in the ABC or GCB subtype from all the studies that have been done, but are certain genomic characteristics important in terms of predicting response to CAR T cells? And I've shown you the results with high-grade B-cell lymphoma. I think that's really interesting. Also, it's interesting that this therapy should probably work very well in Burkitt lymphoma, but it's been very difficult to study that because when these patients relapse, they haven't a lot of time to go on studies. Should high-grade B-cell lymphoma as an entity be approached differently? And which groups may benefit from upfront novel CAR T-cell therapy? So there was a trial, the ZUMA-12 trial, which looked at giving high-risk diffuse large B-cell lymphoma patients CAR T-cells in the upfront setting. And the ZUMA-23 study is going to look at CAR T-cells versus standard of care in newly diagnosed patients with diffuse large B-cell lymphoma. And then finally, where will MRD fit into the landscape of CAR T-cell therapeutics? So with that, I thank you for your attention, and I'm happy to answer any questions.
Thank you very much also for staying in time. The talk is open for questions. I have a starting question. So in the light of your experience, are there any markers or risk factors that you weigh specifically and that would make you stay away from a CAR T-cell treatment in a specific patient, or a combination of one or two factors? Or would you give CARs to anybody?
Yeah, I mean, I think it's a real individual decision. I mean, there's been a huge amount of talk about this, that the patients who are on the studies are not exactly the patients that we see in clinic. So it's a really important question. Who's truly eligible for CAR T-cell therapy in terms of relapse patients? I mean, I wouldn't exclude any patient from CAR T cells. Obviously, their performance status is important if they're going to be able to tolerate it. We've actually treated a few patients who had a history of solid organ transplant and developed lymphoma in the setting of that, and did really well with CAR T cells. So I certainly wouldn't exclude that group, but I think in answer to your question, I wouldn't exclude anybody, but use the other kind of judgment factors that we have to select patients for a particular therapy.
But so special groups are not excluded, like post-transplant patients, etc. So that's interesting.
I mean, they have not been included in the pivotal trials, but I think it's standard practice. There's a lot of data where CAR T cells have safely been given to these populations.
Yes, Michael?
Yeah. Do we have time for questions?
Yeah, sure. Yeah. One more question. Okay. Short and short.
Okay. So I'm wondering what sort of perspective is on the emerging data of certain genetic markers being associated with better or worse outcome after systemic CAR therapy. The Merck antigen Odi just showed other examples. What do you think would be the consequence? And would we then prefer other treatments in certain patients, or would it rather suggest that we treat patients with a higher dose of CAR T cells, or maybe 2 subsequent doses, or maybe do combination treatments to address those patient populations that we think are more difficult to treat?
Yeah, I think it's incredibly complicated because there are so many factors that determine how a patient is going to respond to CAR T cells, and so much of it we don't completely understand. CAR T-cell persistence, are there different biological subtypes that do differently with this? The role of the tumor microenvironment. A lot of things happen before a patient gets CAR T-cells that probably impact their outcome in terms of pre-CAR T-cell therapy. So there are almost like 100 different factors that are just up there and not really sorted out. And of course, in clinical trials, we're trying to answer all of these questions. But I think there's not a specific answer to your question, unfortunately.
Okay, then thank you very, very much.